Hi, everybody. We will be starting shortly. So welcome to our session. So people are coming in. Thank you for your patience. Let me share my screen here. So that you see that we'll be starting soon. Apologize for the slight delay, but we have a great presentation for you tonight.
He's having some trouble and I'm not sure what's happening.
Text me, we're broadcasting live. We're broadcasting, so.
I'm gonna go off video now.
Okay. Actually, so Dominga there is in the chat box. So if you'd like to, if you have any comments, it'll be Dominga in the chat box, and we'll be answering questions later with Dr. Sponseller, who we're trying to get on. And we will start in a minute. We're going to get Dr. Sponseller on, but I think we can start because we can start without him. Don't tell him I said that. So, Barbara, don't tell him I said that.
Don't tell him.
I'm Eileen Michelli, and I'm the Chief Program Officer for the Marfan Foundation. I also want to introduce you, like I said, to my colleague Dominga. She's going to be in the chat box. I wanted her to say hi, but now she's working with Dr. Sponseller to get him on. So you can say hi to her in the chat box. Welcome to week 2 of the International E3 Summit, Educating, Empowering, and Enriching Our Community, brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at Worsen. We thank you for making this summit truly historic. As you can see, it is by far the Foundation's largest event, with almost 2,700 registrants from more than 70 countries. And you can see from the picture, people are here from literally all over the world. Not only are they far and wide, but they not only have Marfan syndrome, but there's more than 400 people here with Loeys-Dietz syndrome, more than 140 with VEDS. There's people with Stickler, aortic aneurysm, and also other related conditions. What's really gratifying is that more than 300 medical professionals are also taking part in the summit, which is really great for all of us. And they also want to hear from the leading experts on Marfan, Loeys-Dietz, VEDS, and these conditions. So before we go on, I do want to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction. Before we start our presentation, I do also need to share with you that the International E3 Summit is a forum to provide an open discussion of issues related to genetic aortic vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or Worsen.
Good.
So they're broadcasting live.
If you hear different, Dr. Sponseller's here now.
So do you know when I'm supposed to do anything now?
We hear you. If we hear difference, if you hear differences of opinion from speakers and want further clarification, please contact our help center at marfan.org/E3ask, and please be patient because the volume is high right now. So today we are here, fortunate enough to have 2 speakers with us, Dr. Paul Sponseller from Johns Hopkins and Barbara Lerman, who was from New York. Dr. Sponseller is here. Do you want to just say hello before we do the presentations? We can't hear you. You're on mute.
Hi, I'm Paul Sponseller from Johns Hopkins in Baltimore. Good to talk
We're so
to everybody.
glad to have you with us tonight.
Thank you.
And as we're about to begin the presentations, I want to remind you that after this session, we'd love for you to go into the app and rate it. So just click on where those 3 stars are, and it'll take you into a survey, and then you can give us your feedback. We really do want to hear it. So without further ado, our first presentation is from Barbara Lerman.
Hi everyone, my name is Barbara Lerman. I have a daughter, Sydney, who was diagnosed at birth with Marfan syndrome. She was born with a 92-degree curve in her spine, which limited her activity and her breathing. She had both scoliosis and kyphosis. Sydney had her first spinal surgery at age 3.5, which is really young, and subsequently had 7 more spinal surgeries up until she was 16 years old, which was just last year. And that was when she had her final spinal fusion. We learned a great deal through each of her surgeries, and I wanted to share some of these experiences with you today. Sydney had traditional growing rods placed, which needed to be lengthened every 18 months. Unfortunately, sometimes these rods would come apart, like you would see on an x-ray, because her back would be hurting, and you would see on an x-ray that the screws came apart from her spine. So some of these surgeries weren't just lengthenings, but they became surgeries to either replace rods or put screws back in. So some of these surgeries became very complicated. Now, although a few of her surgeries were uneventful and she did recover as planned, many of her surgeries yielded complications that we hope to avoid. And I'm going to talk to you about some of the complications that could happen with spinal surgery. One of the biggest complications that could happen, which happened to Sydney several times, is that you could have a spinal leak, or it's sometimes called a dural leak. And basically what happens is that they have to patch up this leak. And if the patch isn't done properly, or, or it just doesn't take, then it ends up making your recovery very long. So that's happened to Sydney many times, and she's had surgeries where she's taken like 3 months to even recover. But, hopefully that won't, happen to everybody. It's not in everybody's case, but some kids are, likely to get spinal leaks. And if you've had one, it's more likely that you're going to have more than one in your, in your future.
Oh my God.
Future surgeries. The other big thing is pain management. Pain management is huge in the recovery process. It's always really important to stay ahead of the pain. And you need to know which pain medications work best for your child. Like for Sydney, Dilaudid works well, but for others, like I've heard Valium works well, or other opiates. But you just have to know which works well, and how you have to stay ahead of the pain to make sure that you're always managing between the pain meds and the Tylenol. Because spinal surgery is just very painful, and it takes a long time for you to be back to walking without pain, and doing your regular daily functions without having any pain. So it really, if your kids are on pain medicine for 2 months, this is the time for them to be on a pain medicine. Like, you shouldn't take it away from them because they probably need it. Even though I'm sure a lot of people are worried about getting addicted and all that. In this case, it's very important that they take their pain meds. Another important thing is that you should not let anybody rush you out of the ICU. This is a whole, going into back surgery is, it has to be a very planned process. It's not a sprint, it's a marathon. You really have to look at the whole situation and say, my family's going to, you have to know where your family's going to be, because, you could spend weeks in the hospital. Even if they tell you, oh, it's going to be 2-3 days, it could end up being weeks, or the recovery could be weeks, or there could be complications. So definitely you need to plan for when that you have 6 weeks that you're not doing anything, and that, things could happen. So I would definitely, make sure that you have a plan in place before going into the back surgery, and don't let them rush you out, of the ICU to a regular floor, because you might be back in the ICU. We've done that many times. So that's definitely an issue. Other things that are important to know is a surgeon will tell you, that the case is going to be 5 hours, but then you're sitting out there and it's been 5 hours and you're wondering what took so long. And it's really, their part of it is 5 hours, but it's an hour prep for getting them positioned, because it's spine surgery. So it takes an hour to even get them positioned. And then the surgeon goes in for 5 hours, and then it takes another hour to get them unpositioned. So it's really you're looking at a 7-hour surgery. And I remember the first time we, were sitting there and we were thinking it was going to be 5 hours, and we got very concerned when we were still sitting there at 6.5 hours. So that's an important thing to know too. But all in all, my daughter's, done well through all her surgeries, and her spine's straight, and she's, been able to manage the process. And I've seen many kids be able to manage this process. I've spoken to many moms, and the kids come through it. It's just complicated, and you just have to know going in that it's going to be a complicated situation. And that's about it. If you guys have any questions, I'm happy to answer any of your questions. Thank you.
Thank you so much, Barbara, for that. I'm going to shut my video off. You don't need to look at me anymore. Now we're going to go on to hear from Dr. Sponseller.
Good evening. It's a pleasure to get a chance to talk with you about my specialty, which is care of the child's spine, especially as it relates to Marfan syndrome. I'm Paul Sponseller from Johns Hopkins, and even though this year is different, it's good to get together and try to update you on what we do. Starting with a little bit of orthopedic humor. You've all heard the term, we've got your back. That's what we try to do for you. It's important in orthopedics to understand how to communicate effectively. We often use very technical terms that are structural in orthopedics with the names of the different bones and the different angles. It can be very overwhelming, emotional, and scary. Therefore, it's important to have repeated discussions with your surgeon, oftentimes coming back several times to get decisions made effectively. Often it's helpful to get a second opinion, and doctors don't really think badly of that. They understand that that's a way to get a different perspective, understand things from a different point of view, and overall helpful. It's also important to use visuals, to look at models, to look at x-rays, to look at pictures, and to look at things online, understand what's going on with your child's spine. So the structure of the spine is very complex. There are 25 vertebrae stacked on top of one another, 7 in the cervical spine, 12 thoracic, 5 lumbar, and 1 sacral vertebra. And these have the function of anchoring and shaping the skeleton, holding it together, also separately protecting the spinal cord, which is very soft and vulnerable. And it provides controlled mobility by the muscles acting on this flexible but strong spine. So people think that the spine by itself is strong and unyielding. We have words in our language, terms and expressions that indicate that, like show some background, or he or she has a lot of spine. But actually, it's not intrinsically stable over time because it has a balance of stabilizing and destabilizing factors acting on it, which can make it develop quite a curvature as time goes on. So the stabilizing forces are the rib cage, the ligaments, and the muscles. The rib cage makes the thoracic spine more stable, although it can still rotate. The ligaments hold it together and allow controlled flexion and extension. And the muscles produce the movement, but also hold it in spine when things try to deform the spine. The deforming forces are growth, gravity, and osteoporosis. The spine grows 30 centimeters over time, and this is the most important force because the bone is pushing upwards against gravity and against muscles, and this force is really tremendous and can cause the scoliosis to develop during the growth spurt. Gravity is also an important force, and when the child's spine is upright, it can tend to tip once it starts to deform and make that become much worse. And in adulthood, it also produces deformity even when you're done growing. Osteoporosis, or low bone density, can cause the bones themselves to deform and become wedge-shaped and possibly add to any curvature that's developing under the influence of gravity and forces. How do vertebrae grow? Vertebrae grow from the cartilage discs that are on each side of the intervertebral disc, and they grow about 1 millimeter per year and even faster in adolescence. That's why in the adolescent period, curvatures that may be small to moderate can become quite severe, seemingly very fast. We give scoliosis a number based on an angle of the vertebrae, the angle of the curvature. We call this the Cobb Technique. And I'll show you briefly how that's done just so you understand what's going on. We measure from the top of the curve to the bottom of the curve, drawing lines at each of those vertebrae, the top and the bottom, trying to span the curve as much as possible. In other words, make the number as big as it could be, and that defines the whole curve. And then we draw perpendicular from those two lines. And you can see how those green perpendiculars intersect. And then we measure the angle between those perpendiculars, and that's called the Cobb angle. And that's the angle you'll hear your doctor refer to when we're checking and comparing and monitoring the spine in the presence of scoliosis. That angle hopefully will stay stable and be close to zero. But if a curve develops and time and growth take place, that can increase. And especially when a child hits a growth spurt, that curve can be quite severe. As you can see, this child going from birth to age 4 to age 8, and then age 16, it takes off and becomes quite severe. And that's just the same child growing over time. In Marfan syndrome, there are some differences. They may develop deformities such as scoliosis and kyphosis more commonly than an average child. But not all require bracing or surgery. Some of them are remaining mild. If a curve develops, it may increase at a faster rate. And patients with Marfan syndrome have an increased incidence of pain or discomfort in their back. So the deformity develops as an imbalance between the stabilizers and the destabilizers. If the curve is less than 20 to 25 degrees Cobb angle, this is considered mild and many times will not become a problem. However, if it passes 25 degrees, the speed of the worsening can increase. And that's when we start to take notice and need to monitor them more frequently and sometimes intervene with various options that we will talk about shortly. What about brace treatment? Bracing is often used for halting or slowing curves in Marfan syndrome. And we often hope that the brace will stop the curve altogether, maybe even make it a little bit better. But in Marfan syndrome, because of the ligamentous and muscular factors being different, the success rate is not as good. We don't usually stop the curve, but we can slow it down and make it maybe progress less, or we may make it not need surgery or delay that surgery. So we like to start bracing early. Often if the curve is 15 to 20 degrees, we will offer the brace. I also like to avoid bracing when there's a low yield, a low chance of success, such as bigger curves that are 40 or 50 degrees or more. Oftentimes the ribs are sharp on one side, the skin is thin, it's uncomfortable to wear and therefore it doesn't get worn. Kids may be having several surgeries in a row for other things, and that all impairs the effectiveness of bracing. So I think those are situations where it's probably not appropriate to put kids through bracing. But in general, 15 to 20 degrees in a Marfan patient is where bracing should be considered to get a good start on the control. If the curve increases, we often offer something called a growing rod, which is a series of rods that can be expanded over time, either manually or automatically, and can stretch out that curve and straighten it and function as an internal brace. These are most often used in infantile Marfan syndrome, patients who are getting curves before the age of 3. They have severe challenges ahead of them with so much growth left, and knowing that growth will make the curve worse, we will often have to resort to this because casting and bracing do not work. So we try to preserve the growth, not stunt the growth of their thorax or their abdomen, and try to defer any kind of final fusion until near maturity. So this is a patient who had infantile Marfan syndrome. You can see the spine was very sharply curved. There wasn't very much padding over it. bracing was not tolerated by this patient. And she had such a big curve at such a young age, so we had to intervene in early childhood with these growing rods. You can see how they're inserted through 2 separate incisions, and they can really control and straighten out the curve. Again, functioning as an internal brace that grows with them and helps their spine to stay straight as they get taller. Finally, many patients will need a spinal fusion, which is a permanent stabilization of the spine in the best position. Usually this involves pretty much the whole thoracic and lumbar spine, except for a little bit at the top and the bottom. And rods will hold it straight, but the fusion, which is biological growing together of bone, is the only factor which will last. If you put rods in without fusing, they would eventually break, just like a car axle will break if the wheels are out of alignment over time. Or a coat hanger will break if you keep bending it over and over again hundreds of times. So you need both the rods and the biological growing together or fusion of the spine to correct the spine. But we just say fusion because that's the shorthand expression for what we're doing. Spinal fusion is used typically for severe deformity of over 45 to 60 degrees if it's likely to affect lung function, overall balance, cause pain, or cause worsening of the spine. This is a Marfan patient who has a pretty severe curve, and this person is still growing, so she needs a spine fusion to help straighten up and hold the spine in place. Commonly asked questions are, when is it best to have the fusion surgery? I recommend as close to the end of the growth as possible, or at least after the growth spurt. And if you're a parent, you'll know that the growth spurt in girls is usually around 12 years of age, and boys 13, 14, or maybe 15 years of age are the common ages for the growth spurt. So we'd like to get people to that age, if at all possible, before doing a true spine fusion, because then you have less than 2 centimeters of growth left in the spine, and that is a good time to correct it. On the other hand, some people ask, is it ever too late to do the surgery? And the answer to that is really no. You can do it at any age, but it becomes much more difficult to do and to recover from as a patient, and also more risky to undergo in terms of the complications we will talk about. So what about the details? How long is the operation and what exactly is done? The surgery typically takes 4 to 5 hours, including the anesthesia. And the steps are to make the spine more flexible and sometimes do some work on the joints and the bones of the spine to bring them into place. And then we insert screws or wires or hooks to anchor the rods in place. And then we align the spine using those anchors along the rods and straighten the spine, as you can see here. So this is the same patient before and after. And you can see how the rods being straight allow the spine to align along its course. In Marfan syndrome, the flexibility improves correction so that an anterior approach, in other words, going through the front of the spine, is rarely needed. Even if you have a big curve, you can straighten it out going from the back. So it's almost never necessary to go through the front for Marfan spine. How much of the spine to fuse depends on the curve itself, and oftentimes we have to choose levels which have good strong purchase for the hooks or the screws, and sometimes that even involves going to the pelvis. In other words, these screws at the bottom anchored into the sacrum and ilium to help provide stability over the long term for the spine. Patients often wonder, and hopefully ask, after surgery, what's the recovery time and how long are they in the hospital? For a spine fusion, usually that's 4 to 7 days in the hospital. For a growing rod surgery, it may be about half of that. Patients with Marfan syndrome will typically start in the ICU so that their heart and blood pressure and lungs can be monitored most closely. And then they will typically be transferred to the floor in a day or two. And if there are no lung problems, they may be discharged in well under a week, but you just have to remain open to the time that's necessary. If there are problems, it could be longer, but eventually you'll be discharged. And you can decide at that point whether you want to go home or go to a rehab hospital to gain strength under supervision with more intensive physical therapy, help with feeding, help with pain control. And this all typically causes school-age children to miss at least 1 and up to 3 months out of school. And it takes 3 to even 6 months until the person feels really normal again and isn't thinking about their back anymore and can resume normal activities and do what they normally would want to do. It's also important as a patient or a consumer to understand what the risks are and the expected course. It's common to wonder whether follow-up procedures will be needed. Usually in successful spine fusion, there are no follow-up procedures, but about 5% of the time, there may be a need to have another operation if an area didn't fuse or if a new deformity develops above or below the scoliosis. In Marfan syndrome especially, failure of this fixation by the screws is the most important complication. And you can see in this patient, these screws actually pulled backwards on one side and they didn't hold, so that had to be reoperated to put them back in again. This is necessary because of the thin lamina and narrow pedicles. So why are the differences in Marfan syndrome compared to other patients who have spine surgery? Well, they have lower bone density. Marfan patients often have thinner pedicles, and you can see that here. The pedicle is this area here where the screw is typically placed, and if it's very thin and hasn't got a channel for the screw to go through, it can't hold as well. Or the hook or the wire passing around the lamina may be in some very thin bone. And that thinness is caused in part by dural ectasia, which is the expansion of the spinal covering filled with spinal fluid and making the bone weaker. So those areas, I think, can affect the bone and affect the way the rods are held into the spine. There are other conditions similar to Marfan syndrome. One is called Loeys-Dietz Syndrome. This is an associated condition, which is a TGF-beta receptor mutation. These patients have many similarities to Marfan syndrome, but also have increased space between their eyes. They paradoxically have foot deformities like club feet, and they may have instability in the neck either early or late in life, which needs to be checked for at the time of any fusion or surgery. On one hand, they have flexibility in their spine, but on the other hand, they have contractures in the fingers and feet in certain areas. Another related disorder is Ehlers-Danlos syndrome, which is a defect in collagen or the processing of collagen. There are many types of this, but the classic type is the most severe, and these people often get scoliosis. The hypermobility type, which is the mild form, typically does not get scoliosis. And there are 2 other types called the kyphoscoliosis type and the arthrochalasis type, types 6 and 7, which may be prone to getting spinal deformity. So in Ehlers-Danlos syndrome, you want to avoid going in the front if at all possible. You want to avoid fusing short because they will often add on and need to have more extensive fusion later on. And then finally, it's important to know what complications can occur after spinal fusion. The most common one is infection. Normally, in any kind of surgery, we like to have infection rate be less than 1%. But in Marfan syndrome and many other syndromes, their infection rate is higher. And we try to prevent that by using broader spectrum antibiotics, difficult cleaning protocols for the spine. And if it happens, we often have to reclose the spine. Another complication is reoperation for failure of fixation. Another complication is increased bleeding, especially if you're on blood thinners. And then other organ complications can include pneumonia or need for more prolonged ventilatory assistance. But it's also important to remember why we're doing the surgery. It's really to prevent further problems which will happen due to time and gravity, such as pain, breathing difficulties, sitting difficulties, and increasing collapse of the body. So this is a patient who was recommended for surgery at one point and then deferred it. By the time they got to this point, the surgery was much more difficult, took longer in the hospital, and involved an increased risk. So it's partly preventative, really, to avoid complications becoming so severe that the risks are high. So in summary, the spine is a very dynamic structure with gravity and growth being deforming forces. If you intervene early, you can often support it with a brace or in some cases a growing rod. You want to try to achieve reasonable growth, but surgery in the form of spinal fusion may be needed in some cases. So hopefully understanding this whole spectrum of growth and options and care can help you to understand what's best for your child's spine. And we're available for consultation and questions if you have any further questions about these principles that we've laid out. Thank you. See you next year.
Thank you so much, Paul and Barbara, for that. Barbara, for your perspective, and Paul for that incredible presentation. We have a lot of questions, so get ready. So we're going to get right to it. The most popular question asked, a grandparent says that the 6-year-old grandson's spine is just beginning to curve. Is there anything we should be doing now to prevent any future complications? So. Yeah,
that's really a critical question, because if non-surgical treatment is going to work, it has to start early, but not every little wiggle is going to develop into a big curve. So I guess it depends what the degree is, and that goes back to that slide we showed about how we measure the angles, and the curve can be given a number, and if that number is close to 15 or 20, then I think bracing would be indicated, and that brace should be worn as many hours per day as possible.
And so then a related question, so if you go to the bracing, so by detecting scoliosis early and using bracing, you could, the bracing maybe could push off the spinal surgery or prevent it? Is that the idea?
Yes, exactly.
Okay, great. That was easy. Okay, good. Moving on, can we talk about instability of the neck or a curved spine? Can those occur at any age? And what can be done to prevent this or improve the implications? And how frequently should x-rays happen to try to pick this up early? And this particular parent has a 5-month-old baby with Loeys-Dietz syndrome. Doesn't have any issues with this, but is concerned about this problem.
Another great question. This applies to a lot of listeners, I'm sure. Marfan patients rarely get neck instability, but back in the old days before we knew there was this thing called Loeys-Dietz, there were some that, were said as having that. It really is a phenomenon of Loeys-Dietz. It tends to occur in most cases in older children, but in some of the more pronounced forms of LDS, it can even occur early. So x-rays should be done at the time of diagnosis when the first confirmation of LDS is made. And then depending on what you see, if it looks totally normal, then just follow the patient visually and look for any changes. If there is a concern, then you can do the x-rays every 1 or 2 years, putting it in context with how the child's doing.
Great, thank you. Barbara, I'm gonna start with you on this one. How do children adapt to the new normal after surgery? Sydney's been through so many, so I want to get your personal experience, and then we'll go to Paul for his medical opinion.
So I think that it depends on how old the child is when they have the surgery. My daughter had it very young. So she had it when she was 3 and a half, her first surgery. So she never really had like any other life other than having rods in her back. So she never really had that whole adjustment period. I never felt like she, had the adjustment, but I do feel like that as kids get older, like if you have it at 8 or 10 or 12, I think it's harder for them to adjust to not being able to, roll and tumble and all that stuff. But my daughter never did that because she was so young when she first had it. But I definitely think it gets harder as you get older. I think Paul would probably agree with that.
Yeah, Paul, what you say?
Yeah, I agree with that. The surgery does make them all of a sudden quite a bit taller. We actually just coincidentally did a surgery on a girl today with infantile Marfan, pretty similar to Sydney's age. And she gained about 3 to 4 inches in height from being straightened out. So that really takes a lot of adjustment. And you do move differently. You can't just kind of wiggle and bend the way you did before, but you can stand taller. And overall, the body does better when the lungs are at full size and the abdomen is not compressed. So there are some benefits, but it does take some adjustments. Kids can usually work with physical therapy if they need to. They learn how to walk relatively quickly right after the surgery. Typically, the surgeon does not put any restrictions or brace on the patient.
Great, thank you. Another question for you, Paul. My son's scoliosis is getting worse. Should I consider a scoliocamp before surgery? So I think, what is a scoliocamp? And should that be considered? And then what are the latest techniques for fixing the problem? So I think you talked about the rods, but if you can maybe just reinforce that.
Scoliocamps are conservative therapies, which are generally a reasonable idea. They focus on nutrition, they focus on exercises, sometimes bracing. They are often run by non-surgical specialists, such as either chiropractors or physiotherapists. And they're in certain regions of the country, but not really everywhere. It's hard to say what they do to slow the curve down. I don't think they really can meaningfully slow it down, but they can help people to adapt to it a little bit more. It is investment of time and money. It's hard to say if that's really worth the time spent. We do believe that the best way to slow the curve down is bracing. And then when surgery is necessary, there's really no benefit to the other therapies in terms of helping the curve. So I think, that's that part of it. You asked about other therapies.
Yeah. So what is the latest? What's the latest technique?
The latest technique is still the use of magnetic rods, growing rods for very, very young kids, under 7 or so, who have so much time they need to really grow. And then for older kids, a different form of surgery can be either a pair of rods that'll hold from the back, or sometimes we put something in from the front called a tether. In Marfan syndrome, that doesn't always work so predictably because the spine will often curve above and below that, but there can be some cases where that works, and the surgeon can discuss the pros and cons of that with you. There's no real technology to kind of make the spine preserve all of its motion on a long-term basis, but we're always working toward those ends, and hopefully in the future we'll see less invasive techniques, but we want to make sure they're safe and that they actually work.
Exactly. Barbara, Sydney has rods?
Yes, but she was before the magnetic rod world. Like she got growing rods. There was no magnetic rods at the time that.
Okay, so that's a different situation. Okay. Somebody else is writing that their 9-year-old daughter is about to have her spinal fusion surgery once the COVID cases lower where they live, and they're worried about the whole COVID situation, having surgery in this world right now. So what is your advice on that, Paul?
Yeah, that's a great concern. We now in the hospital have quite a bit of experience about how to screen for COVID, keep it out of the hospital, keep kids from getting any complications. In a children's hospital, the rate of COVID infections is really quite low. There are not typically people on ventilators who are nearby their child with COVID. The staff are screened regularly for COVID. Patients are also screened before surgery for COVID so that you don't come into the hospital and then spread it anywhere. And the anesthesiologists take great precautions during the starting and finishing of surgery to minimize any risk to people in the hospital. So really it's a very controlled and safe environment. If you have to have surgery, really the main limitation is we can't function as efficiently as before because we have to take all these extra precautions. So it takes longer to get your surgery scheduled and to happen. But if you actually have it going on or going forward, you can be reassured that there is essentially negligible increased risk to your child. And Marfan patients do not seem to be at any greater risk of acquiring COVID during an exposure than anybody else.
Right.
Of course, if you actually do contract COVID, then that's unfortunate but very rare. It's an additional challenge that we can't dismiss. But the chance of getting it from coming to a hospital and having a surgery is very, very, very minimal, and probably should not be a factor.
Oh, thank you for that. And I think that just gives me an opening to remind everybody about all the COVID resources we have on our website, and that's at marfan.org/COVID-19. And Domingo will put that in the chat for you all. So I know there's a lot of questions about that people have about that. So here's a question I'm going to ask both of you, one obviously from the medical point of view, and then from the parent point of view. So Paul, any tips for preparing a 6-year-old who has a history of medical trauma for the halo traction and spinal surgery experience? Like, how do you start preparing them? When do you start? What kind of language and terms do you use to talk to children about it?
We didn't talk during this lecture about halo traction, but halo traction is a way of gradually stretching and straightening very severe curves. It's really very rarely used in Marfan syndrome patients because they have such inherent flexibility that you don't often need to go to that step, but sometimes you do. That means an extra week or 2 or more in the hospital, getting that correction, getting that height back. The halo itself is put on under anesthesia or sedation so the child doesn't feel it. And the halo, even though it's anchored into the cranium, is not painful. Kids can eat, walk around, they can be in wheelchairs, they can be in walkers, they can jump and be very active. It's very comfortable. So again, make sure that this is really needed for the child, but if it is, it's something that is not as bad as it sounds. And I would probably focus on the positives, focus on what the child's going to get out of it. They're going to get improvement in their shape. They're going to get a lot of positives. I wouldn't dwell too much on the pain, but just say what the physical reality is going to be, how long it's going to take, who's going to be there to help them. I wouldn't probably dwell too much on the negatives because they will turn out to be, I think, quite manageable.
Yeah, you probably have to set a good example for them, right, Barbara? So I know Sydney was very small when she had her first surgery, but there have been others. So how do you prepare a child at different ages for major surgery?
Are we talking about, are you referring to the halo?
Well, no, I think not only about the halo, because I don't think she had that, but I'm just saying if you're having a spinal surgery and you're going to the hospital for this, and it sounds like it's gonna be a long haul, and they hear from their doctor this long in the hospital, this long till you feel normal again. How do you prepare your child for that?
Well, so one thing I will say, because I just want to go back to the whole COVID answer also about, going into the hospital under those circumstances. I just want to say that for any parent like who has a child who's going into surgery now, I feel like unless it's like absolutely necessary to not be going into it in this, while there's COVID going on, while it's not completely managed, because for several reasons. One big reason, it has nothing to do with like the surgeons or the operation or anything like that, but from the standpoint of like there's only one parent that could be in the room at a time, like it's very difficult to be a parent in a hospital for even 10 days or a week with all this going on, and if your kid has complications or anything, it just lengthens the stay. And it just makes it really hard. I've spoken to a couple of moms recently who've been in the hospital during COVID with their kids, and it's just been it's just made like a terrible process even harder. So unless your child really needs to have surgery, I wouldn't suggest it, at this time. But going back to answer the original question is about preparing your child. I don't know if there is a way to prepare your child other than to say it's going to be a long road, and you take it slow and you take it one day at a time, and whatever comes about, and you just have to deal with it, and it's going to be a process. It's not just going to be, for some kids it's simple, and hopefully will be simple for your child, but for some kids it's not, and I think every situation is different. And it's hard to prepare for it other than to say that, mentally prepare that it's going to be a long road, potentially a long road, hope for the best, but plan for the worst.
That's great advice. So in terms of post-surgery, Paul, what are things that the child needs to do differently after having spinal surgery? Will his back be more stiff? Can he bend down to touch his toes during exercising? And what's that process like? When does all that happen?
Sure, I can give some generalities, but the surgeon will probably have to fine tune that based on how strong he or she thinks the child's spine is after it's all done. But in general, we do try to get people moving as soon as possible. That's better for the lungs. It's better for the intestines and the digestion. So we try to get them out of bed sitting the next day and walking as soon as possible. We do tell them to bend and move carefully at first. When you have to tie your shoes, bend from your hips and your knees. But typically a child recovering from surgery will want to do that anyway because the feeling will tell them to do that. Sometimes there's a good use for physical therapy to help with that. It's important for the parents to understand what kind of help they'll need to give the kids. So, taking time off to be available just to comfort them, to give them company, help keep them entertained, to help get them moving again. It usually takes a good month or two to kind of be 100% normal again. And for some kids, even longer, but there's a lot of variability there. I think dedicating the time, having other family members available to help once you get home can be helpful. Learning how to get in and out of the car with the help of a therapist at first is helpful. But you will figure it out by doing. And your therapists and your doctors will tell you how to lift and help move the person initially. But it's a process. It's pretty common sense, and you'll work it out for yourself with the help of the nurses, the therapists, and the physicians.
Great. Is that what your experience was like, Barbara, for Sydney?
Yeah, definitely. Definitely always needed physical therapy after every surgery. But yeah, we tried to always get her out of bed as quickly as possible, but my daughter was one of those who was always, a little bit slower, and it took her many more days to get out of bed than most. And that's just the way it is. But I do know that for some kids, it's not like that. It's definitely simpler.
Yeah, they're all different, right?
Very variable.
Paul, what are the considerations to choose spinal fusion over rods? Like, what's the thinking?
Well, they actually work together. The rods help to make the spine fuse together. The spinal fusion is the long-term thing that makes the spine stay. The rods just hold it in place to produce the straightening and hold it still so the spine can fuse together. So they're typically done together. Although when you're talking about growing rods, it's not done with a fusion. But when you're talking about the final step, typically that is done with a fusion.
All sounds very complicated. It's amazing what you do in there. Another question about prevention. The 5-year-old daughter's spine is okay for now, but how can I prevent it or monitor, any curves that might be growing, or can they be prevented? What's the situation with these connective tissue disorders?
Yes, again, I would go back to the statistic that about 2/3 of patients don't ever need anything serious, like either a brace or surgery. So that's good news, but you do want to check for it. And that should be done by the well child exam by the pediatrician, or if you're seeing a geneticist, or if you're seeing an orthopedic surgeon, they would check for that every time you go in. And typically we look from the front and from the side. And then we have the person bend over and look for symmetry between the ribs on the right and the ribs on the left side, which can be a sign of that early rotation that's happening. And if it's a mild wiggle, you don't always do anything like bracing, but if it gets to that number we talked about before, then a brace should be used to help slow it down as much as possible. Sometimes it'll stop it altogether. Sometimes it'll slow it and still never need surgery. Or sometimes it'll slow it so you don't have to go through the growing rods, but can just have one surgery. But again, remember that the majority, well over half of Marfan patients never need to have any of that stuff done. So hopefully, you can keep your family in that category.
Great, thank you. Another question for you, Paul. In a Marfan patient requiring a long fusion, can modern techniques prevent the development of flat back syndrome later in life? So we definitely need to know what flat back syndrome is. You have to explain that. And then the second part, is there a way surgically or otherwise to regain a comfortable sitting position when a T3 to S1 fusion surgery and recovery happened a few years ago?
Yes, those are good questions that relate to what we call the sagittal plane, which is looking at the patient from the side, not from the front. And flat back syndrome is when the lower part of the spine, the lumbar spine, is stretched out too much and it pushes you forward, and you have to compensate by bending your knees to kind of look up straight. And that happened a lot when we had older techniques. Now we have better techniques to fine tune the curves that you're supposed to have looking from the side. When you look at anybody from the side, they're not supposed to be straight. They're supposed to have a curve out at the top for kyphosis in the thoracic spine, and a curve inward in the lower spine where you can feel if you feel your own spine. And that's what it takes to keep you balanced and standing up straight and give space for your lungs. So if that lumbar lordosis is pushed too straight, then you can't stand up straight. The other thing you mentioned is, about sitting properly. If you have too much inward curve, that is lordosis, you may find it hard to bend your hips and sit up straight. So that can be adapted. If it's really serious, it can be adapted by a revision. But best would be to prevent that by looking at all the parameters, how your hips are, how your spine, your upper spine is, how your neck is, and planning that all into the surgical correction so that you can stand up straight and be in balance. Great,
thank you. Thank you for that. We're going to go to a question about a 17-month-old with neonatal Marfan syndrome. He was just diagnosed with scoliosis last week. Is it inevitable that neonatal kids eventually need rod placement? And if so, do you advocate for doing that sooner rather than later? And what can they do? Is there anything they can do to stop the curve?
Yeah, that's a great question too. Neonatal Marfan patients often, but not always, need something done for their spine. And generally, the more severe the overall degree of the condition is, the more likely the spine will get scoliosis. And you just check it by visual exam, we call physical exam, and also x-rays if you see something. Early on, you can brace it, and that will sometimes hold it. But sometimes these kids don't tolerate braces very well because they have a lot of other things going on, and they just aren't comfortable being so thin with little padding over their bones. And so that just doesn't work as well as we hope it would. So you're you're left to watch and see how fast it progresses. We do like to defer surgery as long as possible. In the best of all possible worlds, if you know you're going to have surgery, doing it once at age 14 or 15 is perfect. But if the kid's 17 months old, that's probably not going to be feasible. So we do sometimes do those magic rods. Once the curve reaches like 70 or 80 or 90 degrees, we will put those rods in, and then you can really straighten it out quite a bit at that point. But 17 months would be a bit too young in my experience to really do it. Best to postpone it if at all possible to 2 or 3 at the earliest, and just in general as long as possible till it hits one of those numbers.
Yeah, and I'm going to let Barbara weigh in because Sydney has neonatal Marfan, and she had her first surgery you said at 3. So and she's doing well now.
Yeah, and I'm going to say that she had a very large curve when she was born, and bracing never helped, and it was annoying and awful and not worth it. And we definitely stopped during, trying to do it. And I think it goes to the whole thing. If your curve's more than a certain percentage, you just have to kind of wait it out till they could have surgery. And I don't know that I would ever bothering them with a brace. It's not, she had a lot of lung issues, heart issues. It just never worked.
Yeah. All right. Thank you for sharing your perspective. So we have more questions, but it's just about the hour. So I think what I'm going to do is we'll get back to you in the question and answer box about your questions. And let me just share my screen for our final thoughts here as we close up. So again, I want to thank you all for being here tonight. If your questions weren't answered, please submit them to marfan.org/E3ask. I did see a couple of things that are very personal, like this is the curve, is this many degrees, or this many degrees. That would be hard for us to answer. That would be more for your doctor. But if you have general questions, definitely send them to our help center. Just the patient volume is high right now. So obviously because of the summit. So be patient. We'd also, as I said before, love for you to complete the session survey. We want to know how we did today. Please visit the exhibitors in our virtual exhibit hall. They're sponsors of this event, and because of their support, we can offer programs like this for free, actually, to everybody. We also encourage you to connect with community in the app. The conversations going on in there are incredible. People all over the world talking to each other, meeting other people with the same condition. It gives me goosebumps looking at it. And if you'd like to share anything you learned here or your feedback on the summit on social media, please use our hashtag E3Summit20. And then finally, if you are enjoying the summit, if you're appreciating all this information, we want to do more of this for you. And so if you'd like to make a contribution to help make that possible, you can do that at marfan.org/donate. And again, Domingo will put that in the chat box for you all. So once again, thank you all for coming. Paul, do you have any final words in this session?
No, I'm really impressed by the thoughtfulness of the questions. It's great to have Barbara here. It's great to see that she has works hard back there on her shelf from the gala. I think this is all very professionally done, and I thank everybody for allowing us to be part of your journey.
Barbara, any last words?
If you're going to consider spine surgery for your child, you should always go to Dr. Paul Sponseller. Johns Hopkins.
There you go. There's a free ad for you. All right. Well, thank you, everybody. And please enjoy the rest of the summit. If you see a session that you missed, that you wished you didn't miss, the recording is in the app. So have a good night, everybody. And we hope to see you again soon. Take care.
Thanks. Bye.
Bye.